kind of segue into some of our patients' stories as well, but we'll do that by starting with Sharon Sledge, Bloodless Medicine and Surgery and PBM friend and colleague. Currently is working at the Bloodless Medicine and Surgery Program here on the East Coast of the United States at NYU Langone Health in New York City. So Sharon, thank you for being here. And if you again could speak a little bit to your program, but also how, again, we're here and talking about maternal and child health. So how we apply some of these principles and techniques, particularly in maternal child health in your history and in your program there for safe obstetric care.
So thanks for having me as part of this panel today. So Dr. Spieth actually opened up his presentation by saying that the patient is at the center of the universe. And so certainly all of us on this call no doubt feel that the patient is certainly the center of bloodless medicine. And since we're talking about obstetrics, we would include the family in that as well. So how me and my team approach the patient, we work with them in a way that really promotes empowerment and supports their patient autonomy. And so actually that starts when I first reach out to the patient to set up our initial bloodless obstetrical consult. And one of the the first questions I ask them is I ask them, do they have an advance directive, durable power of attorney, or a healthcare proxy? And I do that for two reasons. One, I want to really ascertain how serious they are, about bloodless. Do they really understand? And also, too, if they don't have a healthcare proxy or advance directive, I encourage them to get one. Secondly, if they have one, I want to ensure that it's filled out correctly because I want to make sure that it meets the legal standards, because that document is going to support them in their patient autonomy to get the bloodless care that they desire and are requesting. So then we move to schedule an appointment. We meet with the patient, and many times their family spouse is part of that conversation. We have an extensive discussion reviewing minor blood fractions, medical procedures and treatments involving the use of their own blood. In other words, we sit down and really have a discussion with them about what blood conservation strategies may be appropriate for them and things that they agree upon. Those are then clearly documented. We have a bloodless medicine and surgery program treatment option checklist that's been uploaded into our electronic medical record, which we use Epic. And that's there for the whole team, for everyone to have access to that. Simultaneously, bloodless alerts are applied to that patient's record so that anyone who enters in and out of that patient's chart is aware that this is an obstetrical patient who declines the use of blood products in her maternal healthcare process. So I know this week we talked a lot about optimizing hematocrit and increasing the red blood cell mass. So we, like Sarah too, have a anemia screening process, protocol, and algorithm for our patients. So all of our pregnant women, and most definitely all of our bloodless patients, do have a CBC at the time that they come for their first prenatal visit. They're all placed on prenatal vitamins that contain iron. Those who have a hemoglobin of less than 11 have an evaluation for anemia, and that includes iron studies. And those who are diagnosed with iron deficiency anemia are also given some additional iron supplements. Routinely at like 24 to 28 weeks, those patients, if their hemoglobin is less than 11, their iron stores are reevaluated. And then if they have persistent hemoglobin levels below 10 by 32 to 34 weeks, despite our best efforts with oral supplementation, they are referred for IV iron. Again, now, when we meet a patient, perhaps if they're already on iron supplements, we may already just move to doing iron studies and referring them from iron infusions. And of course, our bloodless patients, those patients at 24 to 28 weeks, or regardless, have ferritin workers as part of their process. We know that nutrition plays a part of it, so our program, we can facilitate them being referred for nutritional consults to give them some guidance in terms of how their diet can supplement supplement or improve their anemic status, or just to have a healthy pregnancy in general. And then in terms of minimizing blood loss, which again has been a major focus of bloodless medicine and what we do, being hemovigilant. So all of us on the team are always thinking about what can we do to minimize blood loss. So on our labor and delivery unit, we do quantified blood loss, EBL. So we heard a lot of talk about that this week, quantified blood loss. Every drop counts, and we want to count for that. Postpartum hemorrhage, as we all have heard a lot about this week, can happen at any time. So we do have available a postpartum hemorrhage kit that's on our unit with all the associated medical therapies that we discussed at length this week. Minimal blood loss, blood draws again is employed. And we actually have self-saver available on the unit. So we have our own in-house team, so that's available should that be needed. And then another thing that Dr. Spee said today that, again, us who've been around for quite a while know that this is a team sport. So we do employ a multidisciplinary treatment team approach to blood conservation. So we start lining up all our consultants, maternal fetal medicine, hematology, anesthesiology. And as you'll see in the first patient experience that we have, many times when maternal fetal medicine is involved, our group of consultants and team players do grow exponentially. So together as a team, we formulate a plan of care for how we're going to avoid and control blood loss. So that's what we do.
Awesome, Sharon. Thank you. So this is going to be a nice lead-in to our first patient experience. And we have a kind of a group here, including Sharon and Rosanna Aguilar is with us. And also we have the privilege of having with us Dr. Khan, who is the professor of obstetrics and gynecology and the vice chair and division director here again on the East Coast of the United States. And the Department of Obstetrics, Gynecology, and Women's Health, and the Division of Maternal Fetal Medicine and Surgery, so MFM as we call it for short. And he has a very special specialty as a real leader in science of abnormal placentation, which is again a pretty rare find in terms of expertise. So a lot of experience and expertise, and very happy you could be with us here. He's from Hackensack University Medical Center and the Hackensack Meridian School of Medicine, again, here on the East Coast of the United States. So we're going to approach this as sort of a panel discussion. Thank you, Dr. Khan, for being with us, and Rosanna and Sharon. Of course, you're part of the care of Rosanna as well. So we'll start with you, Rosanna, and to talk a little bit about your own situation. Again, the patients at the center, and you've been so kind to share your time with us. Can you tell us a little bit about what happened to you, your surgery, and how it ended up taking place, and the importance of bloodless in your care?
Thank you so much for having me. Yes, I sure can. So the bloodless surgery that I had was a bloodless cesarean section. In 2019, during my pregnancy with my son, Josiah, I developed a rare condition called placenta prurita, where my placenta attached itself to my bladder.
Dr. Khan, could you make just a couple comments on how come that's a especially challenging situation in any circumstance, but particularly in a patient for whom transfusion is not an option?
Obviously, the prevalence and the incidence of abnormally placental invasion is on the rise across the globe and in the United States. But once this invasion occurs, it leads to a major surgical catastrophe, which is bleeding. In fact, patients with true placenta prurita have a 30% chance, if not even 40% chance, of maternal mortality during the time of delivery. So clearly, this poses a huge risk for patients who undergo these surgical procedures.
Thank you. Thank you so much for that insight. We'll hear more about the situation as it transpired. So Rosanna, a little bit more from you, please. Tell us about sort of how you got you approach seeking bloodless care for your situation, and also your reasons behind seeking that kind of care.
Well, due to my religious beliefs, I am a Jehovah's Witness, and I view blood as being sacred, as it represents life. So I take very serious the command in the Bible at Acts 15, 28, and 29, where it says to keep abstaining from blood. So when the discussion came up about my delivery actually needing surgery, I knew that the bloodless surgery was the only option that I had. So when, as far as the steps that I took for obtaining bloodless care, after my local doctor here notified me that he was scared to perform my surgery without the use of blood, we began to search. As previously mentioned in the program before, Jehovah's Witnesses have a group of volunteers and mature volunteers that work together with hospitals and doctors that are known as a hospital liaison committee. So they began to search, and several surrounding and major hospitals actually had denied my case as they were unequipped to handle my case without the use of blood. So the survival rate was, at the time they had told me, was only 2% chance without the use of blood. And they didn't want a mortality on their hands. So therefore, nobody wanted to take my case. And thankfully, the HLC had contacted Sharon Sledge, who was with Hackensack Hospital in New Jersey. And then, sorry, I get choked up. She did introduce me to Dr. Alcon, who performed the surgery for me.
No, don't worry. We're so happy. We're so happy you're here and that things went well. And yes, I know how dedicated Sharon continues to be to making the right connections, and it's wonderful. So I guess for both of you, Rosanna, and for you, Dr. Alcon, again, we said this is sort of a team sport, right? The patient's at the center, but it was a complicated case. Sharon, certainly for your comments as well. Tell us about how the case went, how you approached it clinically, and how things transpired.
It's as Rosanna chokes, it's also I'm human, so I have the same feeling. I mean, if you just listen to what she had to say, she has her beliefs, and obviously we all have our beliefs and our philosophies, and sometimes our beliefs and philosophy may not be on the same page or the same line. But at the end of the day, if no one's going to provide the care to the patient, then that's patient abandonment. So someone has to do it. So as much as this preparation, what Sharon mentioned elegantly, and the rest of the people on the panel, how you prepare patients who are in bloodless medicine programs to optimize their hemoglobin hematocrit so that they could undergo surgery. So therefore, my job as a surgeon is to optimize my surgical procedure to decrease the blood loss. And that is my goal, my objective. Clearly, philosophies are different. Rosanna wants to live, but Rosanna doesn't want to get blood for her philosophical beliefs and reasons, which is respected. I, on the contrary, have the ethics of saving a life. And sometimes, you fight with this, right? Can I, as was mentioned earlier, can a human really live with a hemoglobin of 1? Can you really drive 100 miles more when your gas is telling you that there's only 10 miles left in it? Sometimes it's going to be an impossibility. So the question is, what do you do? So I think because of the complexity of Rosanna, we were able to put an enormous team together to ensure that she gets the best surgical care. Did I go through sleepless nights? Yes. Did I go through various strategies in my head? If plan A fails, we have plan B. If plan B fails, we have plan C, because the objective is there is no way a mother should die from childbirth. There's no way. And that was our goal. That was objective. And of course, medicine is collaborative. There is no I in the word team. And we all have to work with each other in order to optimize our outcomes. So yes, so Rosanna went through a very, very complicated, a very, very long surgical procedure, and I am so delighted that she did well.
Thank you so much for the eloquent way you described that. I think those of us who've been in bloodless for a while can speak, at least in the United States. Folks like you are challenging to find, to work with, and it's always sort of amazing to me that we don't have, I think, more engagement sometimes by our obstetric and gynecological colleagues. Sarah, you're nodding, and so we really appreciate you, but extra appreciate you, because there aren't many who really share that very balanced and compassionate view.
I'd like to thank Dr. Alcon too, because he knows when he sees me knocking on his door and he sees my face, what do you want? And he has never, ever said no. And so we've had many, like you said, some sleepless nights, big team pulling together meetings, rehearsing. But at the end of the day, he was a great leader. He still is a great leader. And we're just pleased to have him as part of the team.
Finish up the story for us. Tell us how things went.
I appreciate the fact that it was a teamwork, because there was at least 30 in my OR that were all together. And going in, I appreciated Dr. Alcon. He definitely, made that point known to everybody that I did not want to accept blood, and make sure that everybody was fully on board for that. And everybody agreed. So that was a huge team effort for them to be able to be all on the same page. He meticulously operated on me, and I was awake to be able to hear his commands. And it was just the most impressive, absolutely, delivery I could have had. As far as the surgery went, everything was obviously a miraculous experience. The surgery was a tremendous success. I'm still here today. My son Josiah is actually here as well. And he and I both, survived without any complications or compromising my beliefs by using other bloodless alternatives. We're living proof that challenging surgeries can be performed without the use of blood. And that was huge, because down here, it just did not feel that way. So I truly do have no regrets. I'm very appreciative to the HLC, who worked tireless on finding a doctor that had the confidence to take my case and who was going to honor my wishes. And I'm truly grateful and appreciative to the whole surgery team, and especially Dr. Alcon, because he took on the challenge. He thought outside the box. He didn't look at me as just a number and a statistic rate. He did beat the odds. So without a doubt, I would definitely choose bloodless surgeries again. And the benefits were remarkable for me. They truly were. I was astonished to just find out that I had only lost 100 cc's of blood, and that was very impressive. I did end up, of course, using a cell saver machine, and there were other alternatives that were used as well. But to only lose 100 cc's of blood was a really remarkable benefit. The recovery time was less. My hemoglobin had increased immediately after delivery. And I honestly, I felt like I was a ticking time bomb. As Dr. Jones mentioned earlier in this program, if we deny and delay, it equals death. And that easily could have happened in my case if I didn't have a courageous doctor like Dr. Alcon. So after being denied by 6 different hospitals down within this area, I truly believe, because of their inability to perform this complicated surgery without the use of blood, I truly believe that it's essential. It is essential for more educational instruction on blood conservation and alternatives everywhere. So I want to thank everybody for their hard work on this program. From me and Josiah.
We're so happy you joined us, and we're so glad you're with us and that things went well. Thank you so much to you, Sharon, for your work to the HLC, certainly, and Dr. Alcon for your dedication to Rosanna, and I know your patients before and since, and more in the future to come.
Thank you both.
And thank you so much.
Thank you all. Thank you.
So we'll move on to another very interesting patient story from down the road, one dear to my heart, from my home institution at Englewood Health. Not a mom in this case. It was a young patient, and I'm trying to look at my screen. Collin, there you are. Good to see you. You're wonderful. So this was again a different case. This was a case that I'll let mom, I think, tell us about, if you can, Dawn, a little bit. But we have with us a surgical team that took care of Collin, and an anesthesiologist as well. Dr. Lobel, who you heard earlier in the week, is on with us, as well as Collin, who was our patient. So I guess we'll start. Dawn, I think you do such a wonderful job telling us certainly a little bit about Collin's history, your family history, and how things transpired as you came to Englewood.
Was a family history of severe hemophilia A. I had one brother who died as an infant just from bleeding after he ran, tripped, and bit his tongue. He bled to death over about 5-6 days. he then was followed. My mom had another daughter and then a son again who had hemophilia A. He and my youngest brother, who died in the 80s, both contracted HIV from blood products that they received to clot their blood whenever there was trauma or an injury. So they passed, and also my sister's youngest child also had hemophilia A and passed away, again, from contaminated blood products. When I had Collin, I had known that I was a carrier. He was my fourth child. I had 3 normal children and normal son, but he too, shortly after birth, they knew that he was a patient, also hemophilia. He did well for a long time. We did some recombinant clotting factor products, so there was no blood in that at all, and he did really well. Then when he was younger, as he grew, we noticed, the doctor noticed that he had scoliosis, which I had also, but his got to the point where it became a concern, and he started seeing an orthopedic specialist. And we were monitoring that, and he was up to a point then where nighttime use of a brace from his armpits down over his hips to try to somewhat mitigate that curve. It apparently, but at the same time, he developed diabetes type 1. He lost a lot of weight, but at the time we were expecting a growth spurt, based on his age. So he appeared to be getting some correction of the curvature, just because the brace wasn't as hard to get on his body. But actually what was occurring is he was losing a lot of weight very quickly because of diabetes. When that was detected, we of course, spent some time getting that controlled, spent some time in the hospital for that. And then after that, we went and got him, went back to the orthopedic specialist, and he noticed the curve had increased drastically. So he sent us, recommended that we go to Shriners in Philadelphia, which they told us right up front that they normally do the procedure to straighten the curvature with blood, that was their routine. But anyway, we ended up, after some searches, again through a hospital liaison committee we used, because we are also Jehovah's Witnesses, they directed us to Englewood.
For any that are interested to hear more, there actually is a video, I think it's up on YouTube, right, Dawn, about Collin's story, but we can certainly share the link of a video that we did, sort of a little more documentary style, because we don't have enough time to tell the full story. But obviously a very complicated case with Collin from the orthopedic, neurologic, neurosurgery perspective, with the scoliosis, and of course, hemophilia is obviously challenging under any circumstances, but particularly when there's a major surgery that we're facing. So I think with that, I'll turn it over to Dr. Steinberger, who is, again, an old friend and colleague, not old, I'll call longtime friend and colleague, working with our Bloodless Center in Englewood for decades on many challenging cases, and Gregg too, Gregg Lobel, who is the chair and chief of anesthesiology and critical care at Englewood Health. And again, as we've said, as many people have said on this call, this is a team effort, and this was a challenging one. We probably don't have time to tell all the details, but I'll start with you, Abe, if you can comment a little bit on why this is challenging even without hemophilia.
Right, this is a challenging technical operation regardless of other issues, but when you add in hemophilia and insulin-dependent diabetes, it becomes super challenging. And actually, we should start with Gregg, because I can't even begin to consider doing a case like this until anesthesia and hematology sorts it out. And they're like my lighthouse in the ocean. They'll guide me. Otherwise, I really can't do this. So they first had to really evaluate and sort out all the options. And once they really tuned everything up, it became a lot less difficult for me because they did a lot of the legwork beforehand. So we should start with anesthesia, I think.
Thank you. As others have said on this, panel, it's all about teamwork. I came to Englewood 25 years ago and did not receive training in, patient blood management or anything like that. But, and I heard ads about it, and I always thought, what magic are they doing? And it's really not magic. It's a little extra work, and it's teamwork, and it's planning. And I think this was really a classic case of the planning. And as I pulled up the old chart, which was prior to us having electronic medical records, so I had to get the medical records to print it for me last week. But we went through a lot of, as Dr. Steinberger said, hematology, endocrinology, surgeons, nursing, post-op care, ICU, and the other item here that made it a little more complicated was the issue of the factor levels and needing to monitor them and administer them at the right dose so that we didn't want to get too low. We also didn't want it to get too high. And our lab did not have that capacity to do that. So we had to make arrangements with an outside lab. We had to make arrangements with transport so that when we drew the lab, it got sent and we got the result back, within an hour or two, not 10, 12, 15 hours when, now what are you going to do? And then we had to make arrangements for a weekend because we needed to continue to do this post-operatively. So that was all kind of the pre-planning. Fortunately, that all went well, and you can never plan too much. So it went well. And then, we got to the surgical day, and everything really worked like a charm. The labs, we got results back, the monitoring of the diabetes, the intra-op use of coagulation testing from ROTEM to normal PT-PTT, monitoring the factor VIII levels, using Amicar, using CellSaver, really using all the tools that we had available to us. And obviously the surgical team. One of the things with whether this is a patient for huge transfusions on an option or not, one of the keys to blood loss in this type of surgery is, moving things along. There is going to be oozing, there's going to be bleeding, and, the longer the procedure takes, the more that goes on. So, really having a plan surgically, which Dr. Steinberger could talk about, is critical. Get to the ICU, and then all the post-op care and the team there, did what they needed to do, as well as, again, continuing the blood management, but and the testing and adjusting infusions and so on and so forth. But really, team effort. That's really what it comes down to. It's not that it couldn't have been done at any other institution, to be honest. In fact, many bigger institutions may have had the lab testing in-house or something, but we put a heck of a lot of effort into it. And Collin, it's great to see you. You look a little different. I haven't seen you in a while. So, great to see you and great to talk about this case.
Thank you. And so I guess we'll have Collin, as the star of the show, comment in just a moment and tell us more about his perspective. But Abe, just a couple comments on, I guess.
Right, I do. First of all, I don't know, because it's an older case, not on medical records, for people who want to see the curvature, it's very, very impressive. It was 78 degrees almost in the thoracic and 51 in the lumbar. That's a pretty impressive scoliosis and very difficult to fix. Post-operatively, much, much, much improved. But look at all that hardware. And it's not just hardware. In order to do this, you have to decompress certain areas of the spine. All of the people think the spine is a bone, but it's very vascular. Bone bleeds. And sometimes in complex scoliosis cases, including this, we are prepared ahead of time to maybe not do it all in one sitting. We sometimes say, we'll stop halfway through if there's too much blood loss and come back. It's happened a few times. Here we lucked out. If I had to pick a case that we would have to two-stage, this would be it, but it went so well. the total blood loss after that entire big from T4 to L4, that's a gigantic surgery, we lost 800 cc's. I mean, that's not much in general, but certainly in a case like this. And we gave back, I think, at least 200 cc's. So he actually, he did great from A to Z. Every step of the way it was going so smoothly. We did more and more. And but we looked and we said, hey, we're done. You know, everything went very well. I mean, anesthesia was on top of everything here. And he post-operatively, I haven't seen him in a while, which is always a good sign, because the ones that keep coming back are the ones that complain. And he's been fine. So very pleased. I see him now. He looks great. Correct.
Wonderful. Thank you,
I
Abe.
remember him walking around the ICU I forget what day it was, very quickly after the surgery. And that, you don't want to have patients in the ICU walking around.
Yeah, he's a tough guy. He's resilient.
All right, so Collin, thank you, Abe. Thank you, Gregg. Collin, it's all about you. So we're so happy you're with us. You look fantastic. We want to hear from your perspective a little bit, Collin, on how this all transpired now with a couple of years behind you to, I guess, look at how things went. Please tell us about your bloodless surgery experience.
Well, like Dr. Steinberger said, you don't really hear from patients again unless they complain. It's kind of hard to complain when you experience what I experienced. When it comes to the surgery that was performed on me, it was pretty much anything but easy. Complex is definitely the word to use for it. You know, with someone like me who bleeds a lot more than the average human, increased risk of infection from diabetes, and as a practicing Jehovah's Witness, I obviously don't accept blood transfusions. And all of these kind of makes for a dangerous trifecta of issues to deal with in a surgery, especially one as bloody as a spinal surgery is. But yeah, I mean, after the surgery, post-op, I was just laying in bed. I think it was day 2. I immediately started walking around the hospital again. And I was not expecting that from everything that I had known of what was going to happen during the surgery. Like when you have I want to say it was a 12-hour surgery, you don't expect to be up and around at day 2, especially when something like your spine is being worked on, which is just such a core part of your like movement abilities. But the things that were done and the strings that were pulled was pretty amazing to see in motion.
Thanks, Collin. We're so happy for your comments and that you're here. And Dawn, I guess Mom Dawn, if you could kind of wrap up the comments. We've said already that bloodless surgery, medicine and surgery really is a team sport, and we're all in the team, family, patient, all of us clinicians. Could you make a couple comments on how you saw that in play, nursing and all these different folks working together?
Well, I'm a retired pediatric nurse. I've worked in several different areas of the hospitals. And I'd never experienced in any of those institutions the teamwork that went into getting everything ready to go. It was watching and listening and hearing about miracles, little miracles here and there. It was teamwork. Everything went down to just the most minute details. And we were astonished at the level of care that he got from weeks ahead of time, and everything just falling into place. And now hearing a few more details that we weren't aware of from Dr. Lobel and Dr. Steinberger. It's still miraculous to us that it happened, but at the same time, you know, we have such faith in our God that he will bless the efforts that are made on behalf of us. And it was even afterwards when we feel honored to be able to share our story, because we felt, you know, before we had any knowledge of what could be done, we felt that it was kind of hopeless, and you know, it was one thing after another that was happening in his life, and the background, how I grew up, and the things that I saw. And then to see the total opposite of that past, with all of the, again, hematology and anesthesiology. I remember Dr. Lobel coming in and saying how he had to, on the fly, put together an infusion system for his factor because of the minute amount. He ended up using something from the NICU, an IV pump from the NICU. And that was amazing too. Those little things that just, constantly these people were thinking and making things better and fine tuning. And the care was great. He was walking the day after, and we went from walking around the ICU to walking around the hallway outside the ICU, and he just did well. Physical therapy, the whole ICU staff, the managers, the peds manager, everyone was involved. They were there. Some of them we didn't access, we didn't have to, but it was amazing, that network. And we really appreciate everything that you've all done for us.
Thank you. Thank you, Dawn, for the kind comments. Collin, one final comment. How's life now?
I'm here. I can stand. That's all I can really ask for.
All right. You look great. And again, huge thanks to Dr. Steinberger, Dr. Lobel, lots of people who aren't on this call too. We worked very hard and collaboratively, but again, Collin with you at the center, and it shows that even these most challenging bloodless cases can be done when we all work together, put our heads together, and keep you in the middle. And we're so happy, Dawn, that you could be here. Give our regards to David as well, the rest of your family, and Collin, so happy again. Thank you for being here. Last but not least, interview is with our friend Elizabeth Effiong, and she was an obstetric patient there at the University of Calabar Teaching Hospital in Calabar, Nigeria. Also taken care of by a team of folks, and I think you are going to not speak to her case a little bit, but Elizabeth, thank you so much for being with us. I'm so happy that you're here. So could you tell us a little bit about the surgery that you had and how you decided that bloodless surgery was the right way for you to approach things?
I had a bloodless cesarean section, and this took place on the last month, 1st of April, 2022.
Very nice. And how did you obtain bloodless care? Why was this important to you, and how did you go about seeking that there in Calabar?
Yes, I first of all went for registration at the University of Calabar Teaching Hospital. When I got there, I met with a nurse who I requested I should be assigned to a doctor who will take care and respect my position as a witness without blood transfusion. And she considered my request and has assigned me to Dr. Okon. When I met with Dr. Okon, I now tell him my stand concerning blood transfusion, and he accepted to treat me without blood transfusion. But at this very point of time, I never knew I had a case of placenta previa. It was later on when I did my first scan that the doctor now told me that I had a placenta previa type 4.
Dr. Usoro, maybe you could weigh in and explain how, again, a placenta previa is a challenge in any circumstance, particularly in a patient for whom transfusion is not an option. How did we help manage Elizabeth in the days leading up to her surgery?
Thank you very much, Sherri. I'm not an obstetrician, but I work with obstetricians, and I was actually invited into this case because the patient requested bloodless surgery. So a former consult was sent to the bloodless surgery unit, which I am heading. And of course, we're informed that she had placenta previa type 4, meaning that her placenta was completely covering the cervix, such that, of course, it's impossible to have a delivery without cesarean section. And furthermore, she will be predisposed to bleeding, antepartum hemorrhage, even during her pregnancy. And even at cesarean section, she will be predisposed to postpartum hemorrhage because the uterus cannot contract very well, the part of it around the cervix. So it's a life-threatening situation if it's not properly addressed.
So from your perspective, how did the surgery go? What was the outcome? What were the benefits that you perceived as choosing a bloodless surgery?
Surgery went well. It was successful, such that 4 days later, I and my baby were being discharged. And as at then, my hemoglobin level before the surgery was in 10 grams. Then after that, at the last moment, I went for checkup, for postnatal checkup. My hemoglobin level rise from 10.1 to 14.1 gram. The doctors really helped in the situation. They took the initiative to build up my blood level by giving me blood boosters like Planteron 12. And as such, even though I bled for 2 consecutive times, different times, the doctors were there. They cared for me by giving me tranexamic acid and vitamin K injection so as to control the bleeding. During the surgery, they were there with me in the theater. They give directives on how to administer tranexamic acid and vitamin K at different intervals so that they can control the bleeding throughout the surgery.
Wonderful. No, thank you, Elizabeth, for sharing that. And I think, and Nat, I'll turn it to you again to have a couple of comments. And again, I think my eyes very much opened when I came to Nigeria a couple of years ago to see how the work happens there. And certainly our perspective, it's not about transfusion, but our perspective on the importance of bloodless may be a little bit different depending on the resource setting and the state of actually the blood supply. Again, for bloodless patients, blood is never an option, but I think the situation with the blood supply, even in terms of infectious risk in certain parts of the world, heightens people's thinking even more as to the benefits of bloodless in general for patients. But could you make a couple comments on how we accomplish these things in lower, I think we all think we have low resources, but even lower resource settings, like perhaps for and Elizabeth.
Thank you very much, Sherri. Let me thank you again and commend you for coming to Nigeria in 2019 to share with us in our bloodless meeting at the time. It was a very great boost to our work because you are highly respected all over the world. So in a low resource setting, the very same principles that apply everywhere else also apply. The same 4 pillars as Dr. Shanda highlighted that we have in bloodless surgery, which is the 3 pillars of PBM plus 1 more. They all apply. It may be that we wouldn't have some of the high-tech stuff, but then again, the surgeries we do might not also be high-tech, but wherever the high-tech stuff is, high-tech surgery is being done in Nigeria, it's also possible to have the high-tech equipment. For instance, a setting where there's open heart surgery being done or transplants and so on. They can add a cell saver quite easily because it doesn't cost that much more than the rest of the equipment. But for, and of course, it would have been nice if we had such for Elizabeth, but clearly we didn't really need it because those high-tech stuff usually, for instance, cell savers, they are only cost-effective if the loss of blood is more than 1,000 mils. And she definitely didn't lose more than 1,000 mils. So what I would like to highlight here are actually preventive measures. Elizabeth booked for antenatal care. That was very smart. And she booked early. I think it was like 2 months. Then the obstetric team, they respected patient autonomy. That is important. They didn't try to talk down the patient or force her to accept their own ideas. They immediately sent for the bloodless surgery unit. So that respect for patient autonomy and possibly having a dedicated unit like we have, because anywhere in the hospital, anybody has a challenge on bloodless care, they just write a consult to bloodless surgery. raised her hemoglobin, which is the very first pillar. I think she went there with hemoglobin of maybe, I can't remember, it was like 12 or lower. But before surgery, it was 14 or 14 point something before surgery. And Elizabeth has mentioned how they gave her how she was given tranexamic acid, vitamin K when she bled. So those who are not bloodless surgery practitioners may look down on those medications. But the fact is that those medications stopped the bleeding the same day. It wasn't like next day or anything. That same day, the bleeding stopped. She was only kept in hospital the second time to avoid something terrible happening at home. So she was kept in hospital from 34 weeks to 37 weeks when the CS was done. Having a multidisciplinary team is important. And fortunately enough, in this case, the surgeon, the anesthesiologist, and I think even the nurse are all members of the Bloodless Medicine and Surgery Group. The Bloodless Medicine and Surgery Group is multidisciplinary. It doesn't have anything to do with religious position. These are people from different religions, but they believe in the science of bloodless medicine and surgery. And they all put their heads together, and the bloodless surgery unit was invited. I was there with my house officer. So that multidisciplinary approach, as we have heard over and over again, is very important, team approach. The spinal and epidural was used, which is well known to be better in bloodless surgery rather than general anesthesia. Now, the timing of medication was important. I think that's what Elizabeth referred to. Of course, she was awake during surgery, and maybe she learned a bit of obstetric surgery and how to do surgeries. I hope she doesn't do them. So, but yeah, we had to direct on some of the timing. Apart from the medication that obstetricians give, like the oxytocin, which was given at the time of incision of the uterus, and again, when the baby came out, and then agometrine after the placenta was out, and at the end of surgery, misoprostol. But we also have our own way of giving our tranexamic acid. We give it preemptively. We don't wait for the hemorrhage. So at induction, we already give 500 milligrams slow push. And then we add another 500 to the intravenous infusion. And we keep adding if necessary. And we know that at 3 grams, we haven't exceeded. And of course, we ensured that vitamin K was given, which many would look down upon, but we use it and it works. Now, the post-op period, we avoided NSAIDs. In my setting, the obstetricians are very fond of giving a non-steroidal anti-inflammatory for pain relief. It works very well, but it increases hemorrhage. So for this case that is predisposed to hemorrhage already, we didn't allow that. We chose other things, opiates and other kinds of medication. And please, let me just share a picture here, so which Dr. Kuhn did not share. I have permission of Elizabeth to share this. Sherri, which day post-op or which week post-op do you think this picture was taken on?
5
Sherri,
weeks.
that's 5 weeks. You missed it narrowly. It was on the 3rd day post-op, 3rd day.
That's fantastic.
So, and she was discharged the next day. That's the 4th day. So as Dr. Lobel said, it looks like magic or some out of the way thing. I agree it's a miracle because I believe someone created us to function in this way. But the fact is, once you follow the principles, the body takes care of itself. So when a patient is not transfused, the wound healing is faster. It's almost magical. And we don't know anything about wound infection. So she didn't have any wound infection, which reminds me of what Collin said about increased incidence of wound infection in diabetes. So that a diabetic patient is a patient not to transfuse, but I digress. So basically she didn't have any problem at all. And she got discharged, she and her baby.
Thank you so much, Nat, for that. And thank you for allowing us to look at that image, Elizabeth. We are so very happy that you're here. And thank you to all our fellow Bloodless Medicine and Surgery Program leaders, coordinators, old and young, mostly old, I think, no, but all of us who have continue in this with the patient at the center, trying to advocate for what's right. And so pleased and grateful that we have so many colleagues in many areas in the team sport, and that the science is further developing to help support the importance of bloodless medicine and surgery.